your own setup, perhaps it gives you an opportunity to record a few atypical procedures. They're not exactly routine cataract surgeries. The only thing that lies on the shoulders of all of us who present these deferred life surgeries is to not record a procedure which is 13 minutes long, and I keep saying this, and then fast forward it while you're presenting from the podium. It should be done well in advance, and we should stick to the 7 or 8 minutes or whatever time limit is given to all of us. So let's begin with, this has got nothing to do with the promotion of any product primarily. It can come and we all discuss about technology, that's for sure, but this is not done with any hope of projecting that product from the word go. You ready, sir?
Yeah, I think what is the big deal about it? Anyway, you're going to use them. Anyway, the industry is going to be after your lives to use them, and ultimately you're forced to use them. You may see. I think you should story, but at least you should do it to see what the results are. So I personally feel there's nothing wrong with it. But then that's how everything evolves, whether it was femtosecond lasers or all the IOLs or all the multifocals or so it's okay even promote or not to promote them, whichever way.
Promotion will come a little later. So what we are discussing is, as I said, technology. Absolutely nothing wrong in discussing technology, ma'am. But what used to happen and what...
Or what is a diet?
So the excitement is one thing that has been my observation. I think it started from BOA. Just after the guidelines came in, BOA was the first conference. And from BOA till OSWB, which was last week, I think I have attended around 7 or 8 different conferences, including ISCRS. And I don't know, please correct me if I'm wrong, I think deferred life sessions are getting more audience than the live surgeries used to. That's my observation, watching from here. So maybe it just catches people's minds a little more. However, I'm not promoting that. I'm completely behind you. Okay, sir, your time starts now.
Thank you, Anurag. And is that I put a siphon tube and make one 2.2 main force incident temporal, and then I put viscoelastics. Sometimes if the patient is uncooperative, I do put intracameral anesthetics. Otherwise, most of the times we do not put any anesthetic inside. Here, dispersive viscoelastic like Viscode. It is a little more difficult and more time taking to do or access with a cystotome. So holding the capsule and rotating it is easier. Hydrodissection. Normally I do 2-side hydrodissections till the nucleus starts getting lifted up, and then tap it down and start. Most of the surgeries I do is by direct chop. So here also I am trying. This is a grade 3 EPS. With some of the surgeries, people start to become vacuum is as a panel mode, and stability. In spite of the fact that you have a high flow rate of 50, I will be discussing about the reason water condition. There are other mechanisms which we will be discussing later. How the surge is protected. So the take-home expectation is over. So people have come down to about 4 millimeters now. I use a bimanual, unlike many surgeons who prefer a coaxial irrigation aspiration system. I prefer bimanual. It's a little more time consuming, shifting hands from left to right, doing one half of the aspiration with one hand and the other half with the other hand. But I think polishing and removing cortex is a little more easier with the bimanual irrigation aspiration cannula. I have a sandblasted tip, so that makes it a little more easier for polishing the posterior capsule, and even if you want to do the anterocapsular polishing, it's easier with this. So having cleaned all the cortex, there are some cortical fibers which was, so I did that also, and implantation of IOL by me is almost always hydroimplantation. So I nudged the cartridge to the edge of the external wound and slowly pushed the IOL. The IOL here used is a new EDOF from Johnson & Johnson, Pure C. So this has the same material as techniques, which is years old and time tested, but there is a little technological difference on the postage surface. So as it unfolds, you can put it in the bag and close the. I think that's all regarding the surgery. It's almost over, I think. And make sure the ostomy is only in favor. So at the end, I give is a new development over their previous model, which has such advantage that it has better surge control and more, and it can glide through hard cataract because of its elliptical movement of the phacotic. So the tubing here is called the advanced tubing system ATS, where it has narrow lumen. Lumen is about 1.27 millimeters, and moreover, so there's a blue coat here. That is a toughened layer which prevents the tube from collapsing. So this is why it is called the advanced tubing system, and it has a hybrid fluidics where the bottle height, because of the gravitational force, gives some amount of fluidic flow. There is also a pump which is already there, which pumps air into the bottle, pushing the fluid faster. So these are the two reasons why you do not have chamber instability. And of course, we all know about this elliptical movement, where there is both a combination of forward and longitudinal and a transverse takeover, which leads to elliptical movement, and the frequency at which it vibrates is about 38.
That means even though the polyp is not entirely going, it's not vanishing, but still it's present, but it's inactive. So what did they do for the rescue patients, those patients who did not respond to ILIA, they did PDT. But that was only 15% of the cases. The molecule size is very small. As you can see the right side column over here, the size is just 26 kilodalton if you compare vis-a-vis with the bevacizumab, which is 150 kilodalton. So because of this small molecule, HFA very potently, and as Santosh Rai was telling in the previous slide, you can see Hawk and Harrier study. These are the very well-known landmark studies having more than some 1,000 citations. Basically, Hawk study, what it did, they wanted to study whether brolucizumab is non-inferior to aflibercept in the management of PCV, and they also studied 3 mg and 602 doses of brolucizumab. So here we can see brolucizumab 2 doses and aflibercept all are same. That means it's non-inferior. It was performing very well equal to the aflibercept arm. And how it was performing better than aflibercept? In the way that the 3 monthly or 12 weekly dosing regimen was extended. That means after they have given the loading dose, this 3 monthly injection, that injection free period was more. That means still a very longer time. You can see till 92 weeks or something, you can sustain the durability effect of this. So that's why it outperformed aflibercept. That means brolucizumab is better than aflibercept in better drying effect, the fluid drying effect, and the durable. That means we can 3 monthly we can or 2 monthly we can inject. So that way it was better than that. And this is a real world evidence of brolucizumab, where they have shown that the better efficacy of brolucizumab. And I'll just show some of my cases. This patient, a very well-known MD medicine spouse, already has received 20 injections for PC. We can see a very beautiful double layer sign over here, and subretinal fluid is there, and vision was 3/60, and after one injection, after 3 months of this, I am taking this photo, very drying effect and 6/60. The patient has received the second injection after 3 months, and also she is maintaining well, very well. So we can see the drying effect is very good, ultra good over here. And let us see one case of CNVM. This gentleman has already received 4 injections, very minimal though, but subretinal fluid is there, vision is 2/60, and after injection was given, you can see after 3 months, better drying and 6/60 injection. I am not saying that it's a magic, it will go 6/6, but imagine the patient who is having 2/60 or 3/60 for many months or years, when he gets 6/60, that wow thing is definitely better. though out of my this thing PCB or CNBM, this is the last slide I want to show, the case that is on DME. So you can see patient is 6/12 and after giving the injection 6/9 is there. So what I want to say over here, we don't reserve it for only say refractory cases. Sometimes in early stages also we do give and results are better. Now to conclude, rolizumab is a preferred alternative in eyes with non-resolving cases of PCB, ARND and even early cases of DME, and the improvement in BCVA, reduction in thickness, macular thickness and increased treatment-free interval, that is more important. The last line I want to emphasize over here, which is discussed in different forums about the inflammation part. So intraocular inflammation, as was noted in Hogan hierarchy, was 4.6%. But in our Indian eyes, the VRSI conducted the study, it was 0.79% only. Prior to that, there are Dr. Devdulla Chakravarti and all, their group, they have published many studies. They have also shown that in Indian eyes, the inflammation is less. So probably some genetic protection for our eyes, or the loading dose that is given in the this Western population that we don't do regularly. Probably these two are the explanations why we do get less inflammation, but whatever it is good for our patient that we do get lesser inflammation in our eyes. So by and large, this is a preferred alternative in the indications of PCB and ARMD and DME. So thank you. That's the end of my talk.
Talks have been so now let's have a mandatory pause. So before we take the photograph, we have something more to do. Okay. First photograph. No, I think with these things, this is for Dr. Bob. Thank you, sir.
अंकुर सर का फोन है ये चलेगा
कॉन्फ्रेंस ने भी लिया
मतलब इससे लिया है और मैंने तुम्हारा जोक कैसे no
That is for
Both
speakers.
cannot take the
Thank you.
Compartment so that the lateral vector should not again reattach to the sclera. So once you do that, then you would end up with getting the great outcomes. So you can see the 2 weeks follow-up. So this is how the right eye has become almost straight with remarkable improvement in primary gaze alignment. Although left eye I didn't touch because sometimes it's very likely you would miss synergistic innervational downshoot. If you see the left eye when the child is looking at the right side, the eyeball is going down. So this particular entity, then I decided, okay, let's tackle this by doing the next step surgery where I would transpose the inferior rectus. So SIDs are very rare phenomenon in patients with COPOM. So those can be tackled by transposing the inferior rectus to the medial rectus. So this particular surgery that really helps to, basically we are trying to harness that extra innervation that goes to inferior rectus by transposing to the MR so that we can prevent the downshoot. So you can appreciate that the left eye ACD has been almost collapsed with a very good outcome. So I think this is how you can treat these particular entities by choosing periosteal fixation and transposition of inferior rectus to MR. I think DRS, all of us know that this has a very typical clinical presentation of palpable feature changes on adduction, narrowing and widening on abduction, upshoots and downshoots. So I will not go into the much details, but they do have a challenge when they do present in a very severe form of offshoot. Like you can see that a grade 4 pumpkin 6 sign, where the eyeball is completely losing in orbit on adduction. So this is one of the differential diagnoses where you can really think what are the indications: primary gaze alignment, improving single binocular field and motility. That should be the purpose. So we have options of doing recession, resection. However, resection is usually not preferred in patients with Duane's retraction syndrome. So again, symmetrical, asymmetrical recessions, they have been known. So they help pretty much in controlling the primary deviation, motility, as well as the abnormal head posture. So you can do unilateral, you can do bilateral, again depending upon how severe is the motility limitation and retraction. This is another surgery which is superior rectus transposition to lateral rectus, where you can use this in patients with type 1 DRS. So it's been more than a decade. We had a very good experience of using this and probably standard of care in patients with type 1 DRS. Another entity is the Y split of the lateral rectus, where you can take care of these offshoots, which I showed, grade 4 offshoot. So you need to split the lateral rectus almost 20 millimeter apart from each other. So 10 millimeter from the center of the the muscle insertion up and down. So basically that leash effect is being neutralized, and the vectors of the muscles are being changed, and they are kind of neutralizing each other to reduce those downshoot and upshoot. You can appreciate here how the left eye is shooting down by +3, and if you see post-operatively, there is no upshoot. So a very effective surgery to deal with this group of patients. Again, Brown's is the limitation of adduction in elevation. It can be acquired and congenital. There are a number of theories. However, telescope theory by Williston and the Wright's hypothesis of tendon shortening or stiff tendon. So here we actually try to lengthen the tendon, or you can in acquired patients, if it is an inflammatory cause, then you can reduce the inflammation by giving steroid either orally or intra-lesionally. So if you see, you can do either isotenotomy or chicken suture. So usually in my practice, I have converted from silicone band expander to chicken suture, which is technically it's quite easy to perform chicken suture. Because at the end of the day, the silicone bands, they are kind of a foreign body you are putting there, so they do have a lot of their own complications. Although if you look at the outcomes, I think chicken suture, they gives less post-operative inflammation, less post-operative complication. So basically, you are putting, you are lengthening the superior oblique by putting the silicone suture there. So how much to do? On table, you can do a force traction test and get that idea. If you look at the literature and my own experience, on an average 8 to 10 millimeter lengthening, that helps in most of the moderate to severe form of Down syndrome. So you can appreciate here this particular child who had a very gross elevation limitation in adduction of -4, and then you can see how post-operatively these patients have been doing good. This is one more entity called as Panda. Okay, so
that may have affected the visual pathways, plus minus the processing motor integration and spatial cognition. Nowadays, we are not using the term cortical visual impairment because it is affecting both cortical and the subcortical level. So brain has its dorsal stream and the ventral stream, where the posterior parietal lobe, the occipital lobe and the temporal lobe, they integrate the most of the functions, that is coordinated between the front of the brain, middle of the brain and back of the brain. We know that the front part is the thinker, the middle part is the doer, and the back part is the seeing things. And many of the children with the CVI, they mainly suffer from the back part of the brain. So the CVI can be an isolated entity where the only visual component is affected. It can be a visual impairment with multiple disabilities. So we have to tackle the child in a holistic way. If the anterior segment or the posterior segment of the eyeball is affected, along with CVI, then we call it as a low functioning CVI. If only the cerebral component is affected, we call it as a high functioning CVI. In India, like the developing countries like India, previously it was the more challenging situation in the developed world. But nowadays, these kids are surviving in a developing country. So the numbers of CVI kids are in the rising trend in India, like the developing countries, where hypoxic ischemic encephalopathy, prematurity and hypoglycemia, these are the leading etiological factors. The children, they present to the pediatric OPD either with refractive error, hypoaccommodation, a congenital cataract, can be a pseudoglaucomatous disc with optic atrophy, prematurity leading to ROP changes, or strabismus or downward deviation. So this is the small example of a 10-month-old girl where the parents brought the child to the pediatric clinic with a complaint of the child has a history of prematurity and low birth weight and already diagnosed as global developmental delay and epilepsy by the pediatrician, but the child has no fixing and following of light, there is no face contact. On evaluation in the OPD, we found that the child has only Menac reflex positive and there is a gross diffuse disc pallor with hypoaccommodation on retinoscopy. Why this accommodation component is so important in these children?
With nystagmus, and this is how the cataract was presenting to us. So when we thought it was a so could not delineate the anterior capsule in these cases, but we started with the capsular. That much of the capsular rexus, I had a problem over there because it was there and it was a little bit fibrotic. But then this is the plaque which is there and it is sitting in the center, and what was we are separating out from that cortical matter. So once I tried to separate out something, what was coming was the fibrosed cortical matter which was there. So we took off the microforceps scissors. What we found is that we call it like a pancake. I was trying to take it out and slowly it was separating from the bulb, and what came out actually was the wing which was lying there, and that was easier to take it out. And so put a good amount of viscoelastic. So in this cases always have cohesive viscoelastic, that will be handy for you. There in the posterior capsule, we were slowly taking it out and it came out in the, and this is how it is finally presenting to us. So after this we did a good cortical wash-up, and then similar capture or anything we could make a single piece. It was a preloaded EV 3-piece IOL, and once I was putting it again, the lens you can see has rotated. So once putting it inside the anterior capsule, I tried to rotate it back into its position, and then it was put in the bag. And as usual, we gave suture in these cases, and this is how the case went on. Always, what do we do? Hydrophobic acrylic lens with square edges are always the ideal choice. And as of all we know, it inhibits the AD migration and posterior capsular opacification formation is delayed. And heparin coated IOLs are preferred for uveitic cataracts. What we always talk about, or always there is a debate about multifocal IOLs, and this is a big no for pediatric cataracts as such. But yes, you can think when they are in their teens, like more than 18 years or so. I think time is up, so I'll not go about the pediatric cataract. I'll just end with my take patients, and with or without IOL surgery and consultation every time, do a rehabilitation, do a underbed therapy, and that is how you can give good vision to these cases. Thank you.
Thank you, Dr. So we'll take all the questions at the end. We'll request.
Today I will discuss some retinal diseases that can manifest neuro-ophthalmological problem. So Why? What is the importance? Because sometimes the retina problems in their early stage, they have very subtle fundus finding or nearly normal fundus finding, and the symptoms that we need to evaluate properly what is the actual cause of the disease. So what can be the symptoms in the paucity of fundus findings that can be doubtful, like hospins, photopsia, visual acuity loss, visual field defect, if there is a ring or central scotoma, or blind spot enlargement. So metamorphopsia, as we know, is a clear indication of macular diseases. So distortion of object is there, and if hospins, that can be elicited in both retinal disease and neuro-ophthalmological some problems. Usually it is affected regarding retina origin, or it is associated with a migraine aura. And pain on movement, as we know, optic neuropathy, there will be pain on the movement of ocular movement. So, and finally photostatic and blind. So I have categorized the diseases and I will go briefly. So these are, I have categorized some groups. So this is called, one is azure complex. As we know, in this acute idiopathic maculopathy, acute retinal pigment epitheliitis, usually these are considered sometimes and mute and multifocal choroiditis as having the same spectrum with predominant viral flu-like syndrome before it, and they usually present with acute some loss of vision and scotoma, field loss. That is very important. Sometimes if you take the help of multimodal imaging, you can find there is some changes in OCT or acute retinal pigment epitheliitis. Sometimes in OCT, outer retina abnormality, you can also elicit. The special acute annular outer retinopathy variant of the azure, and usually it is very doubtful sometimes, especially the retinal features may not have started at that time, and they can present with scotoma, and even if you do perimetry, you can find the enlargement of blind spot. Enlargement of blind spot, remember, when there is associated with papilledema, usually the papilledema has to be very severe before the enlargement of blind spot is there. So you think of any other diagnosis if that severe papilledema or disc is totally normal. So we have also one case where after a very long time with the retinal conditions developed, before that field loss and other, you can take the ERG electrodiagnostic test will give also clue there will be loss of amplitude. So there is condition acute idiopathic blind spot enlargement also.
At the lens like you do in an IOL, and of course you do not go behind the lens to take out the visco. So do a very good visco wash. You don't want to leave behind any visco. The next day the patient will not be happy if he cannot see 6x6. So that sort of brings me to the end. I do not put any pilocarpine, not at all. If I have any doubt, I wait for the people to come back to place, but I do not put pilocarpine, and no stitches for me either. Thank you so much. Patient comes below 45 years of age, we treat only one eye. The other eye we do not touch. We wait till he's 45 years of age and then we touch the other eye. If it is a case of myopia with presbyopia below 45 years, in the non-dominant eye, we give the presbyopic lens. In the dominant eye, we give a plain IPCL. Wait for him to attain 45 years of age and then we replace it with a presbyopic. So that is where presbyopia is concerned. A pure presbyopic, and if the patient comes above 45 years of age, we do binocularly presbyopic. So far I've done very few presbyopic lenses. I have not yet treated a purely presbyopic, but I have one in the pipeline. I can only tell you my experience after I do that. Why don't you start? You are 45.
I'm 30.
Oh right, I forget. 45 is the cut-off age for both the eyes.
Just now you told you were 21.
No, I think you must have heard it wrong, ma'am. I celebrated my 31st birthday barely a decade back. All right, so yes, sir.
What do you think about the clearance extraction instead of IPCL and all those?
About the clear lens extraction, if it's hypermetropic, obviously it's okay. But if it is myopic, we first have to ascertain that the patient has PVD. Because otherwise the chances of retinal detachment are very high. So no, I would prefer a presbyopia phakic IOL as compared to a clear lens.